Good morning, everybody. Thank you for joining us for this live webinar today to help you prepare for upcoming changes associated with the implementation of Patient-Driven Groupings Model, or PDGM, as we have come to know it. Today, we will provide you with best practices to succeeding using Axxess Care, a powerful scheduling and staffing solution. My name is Stephanie People, and I'm the Director of Brand Marketing here at Axxess. So before we get started, I'd just like to give you a little bit of background about Axxess. We are the fastest growing home healthcare technology company, providing solutions that improve care for more than 2 million patients nationwide and trusted by more than 7,000 organizations. We offer a complete suite of easy-to-use, innovative software solutions, empowering home health, home care, and hospice providers to grow their business while making lives better. We have a very collaborative culture, and we're focused on innovation and excellence, having been recognized multiple times nationally as the best place to work. So today, you're going to hear from industry expert Tammy Ross. Having once owned her own home health care agency, today she's the Senior Vice President of Professional Services here at Axxess. She oversees the Professional Services Division with a focus on practical operations solutions for home health, home care, and hospice sectors of the post-acute care industry using technology. So prior to joining Axxess, Tammy served as an executive consultant at Fozzie & Associates, where she used her years of home health leadership experience to assist clients with clinical and operational strategic planning and development. She's a registered nurse with a bachelor's degree in nursing. She holds a master's degree in healthcare administration from Columbia Southern University and has advanced certification in healthcare case management and quality improvement. Joining this webinar is special guest David Murph. David is the founder and CEO of Home Health Gold, which has been providing Medicare certified agencies with extensive data analytics and OASIS scrubbing tools for over 20 years. Prior to launching Home Health Gold, he worked for 11 years as the president and CEO of a large VNA in Central Maine. So in March of 2018, David joined the management team here at Axxess as part of the acquisition by Axxess of Home Health Gold. With that, I'm going to kick it off with Tammy Ross.
We are so excited to be able to bring you solutions for PDGMs and success stories that we can deliver to you using Axxess Care. I have to tell you that Axxess Care is a product that is only and exclusively available to Axxess customers. When I joined Axxess last year, Axxess Care was the main driver for bringing me to this technology company. As an operator, I faced many challenges with staffing, with scheduling, with being able to find nurses and retain nurses. When I watched this product demonstration, I knew that this was going to revolutionize the way we do home care. This particular product has been called the Uber of home health care. And as we go through this webinar, hopefully you'll see how that kind of correlates with Uberization. So let's talk a little bit about PDGM. We're going to talk about what Patient-Driven Groupings Model is about. I'm going to give you the very basics so you have an understanding of how important having solutions and having a plan is early on this year so that you're prepared for 2020. And then specifically, we're going to talk about how you can avoid loofahs by controlling your staffing and controlling your scheduling. We'll talk about rehab management and how Axxess Care can help you still meet those rehab outcome goals. And we're going to talk about one of my favorite skills in home care, management and evaluation of plan of care, which is still a skill in home care. It's been a skill since I've been in home care almost 30 years. And then we'll talk about cost benefits offered through Axxess Care. So PDGM Basis. So the very first thing is that we're going to be moving from a 60-day payment episode to a 30-day payment episode. That means we're going to have increased billing demands on our staff. We're going to actually end up with 2 wraps and 2 finals within a 60-day period. That creates a lot of labor for our support staff. We're also with PDGM, we're going to have a change in what's considered early and late episodes. And reimbursement is actually tied to that. There's also going to be reimbursement tied to community versus institutional. And we'll talk more about that in the coming slides. Comorbidity adjustment. is going to play an important role in PDGM as a secondary diagnosis, and it's going to be extremely important that we support those comorbidity adjustments with our plan of care. Probably the biggest area for most of us is that elimination of therapy domains. There's no longer an increased reimbursement for therapy patients, and that's all therapy patients, OT, ST, and PT. So no longer is 14 a threshold or 20 and 21 a threshold. That goes away in PDGM. We're also going to be moving to 432 payment groups. And within those payment groups, we're going to have 6 main clinical groupings, which are actually the MMTA broken down to create 12 clinical groupings. And this all goes into effect January 1st, 2020, which is, when you think about it, not that long to get prepared. If you'll look at your screen, the presentation here shows on the left our current PPS model. And I like to show these because when this first came out, I thought this was a very complicated model. Having 3 clinical domains, 3 functionals, and 5 service levels to create our reimbursement. So when you look over to the right-hand screen, and if you look up to the top, you'll see our admission source and our timing. And we're looking at community referral, community early, community late, institutional early, institutional late. Of those community referrals and of those buckets, our community late is going to reimburse us less than any other category. So as agencies, we all have threats under PDGM. We all have areas that we may be at risk. If you're an agency that has a tremendous amount of community referrals and very few institutional, hospital, or SNF referrals, you may be at a greater risk than an agency that has a great number of hospital referrals. Looking at the orange section, we're looking at our clinical groupings. And our clinical groupings are categories where diagnoses will fall into. And when we think about this, we have 12 clinical groupings, with most of our diagnoses falling in the MMTW category. In one of those areas, those 6 areas under MMTW. This seems like plenty of diagnoses, plenty of places and groupings. But in fact, what we'll learn when we hear David Mark's analysis from Home Health Goals is coding is going to be a significant risk factor for many agencies. In fact, almost 1/2 of the codes will not create a clinical grouping under PDGM. And what that means to us as an agency, if it doesn't create a clinical grouping, we will not be reimbursed for those codes. Looking at our next level is our functional implementation, our functional scoring, which comes directly from the OASIS. And if you'll see, this is one of the only areas that did not change from PPS to PDGM. There's still going to be 3 areas, low, medium, and high, 3 scores for functional. Some agencies may have a risk in this area, depending on how you score your functional OASIS now. You have a lot of cases that fall in that low area. And if you do, that could be a risk factor for your particular agency. And then the very last section, as we look at this, is our comorbidity adjustment. Up to 30% increase in reimbursement can be obtained from comorbidity adjustment. And that's our secondary diagnosis code. And we think that's going to be great for us as agencies because we know most of our patients come to us with 3, 4, 10, 12 diagnoses. The challenge is going to be that we have to show how we're treating those diagnoses in our plan of care. So unless we have a really good handle on case management and inter-episode management, that could be a risk factor for some of our agencies. Our industry has said that here's some of the main concerns that they have with PDGM. The very first concern is the impact on our therapy patients. There may be an incentive now for us to do less therapy visits. And with less therapy visits, how are we going to still obtain those functional outcomes and quality outcomes that we need for patients? So that's a concern for our industry. There's also a concern to focus on inpatient discharges and to avoid community admission, because we know that inpatient is going to pay us more than community admission. I'm going to show you in the slides towards the end of the presentation how Axxess Care can actually help you be profitable with those community admissions using the skill set of management and evaluation, and how we still want to focus on those community admissions because that's a great need for our patient population. Loofah structure. So now Loofahs are anything less than 5 visits. Under PDGM, Loofah changes. Loofah will be anywhere from 2 to 6 visits, and that is dependent upon a 30-day episode. So in other words, you could Loofah for your first episode and not for your second episode, or you could Loofah for both episodes, or you can Loofah for your last episode, your last 30 days. And I say episode, but it's actually a unit of payment. We're still keeping the 60-day episode, but the payment is going to be in 30 days. And the Loofah is going to be measured in 30 days. So I had someone ask me in a webinar on Tuesday that we presented in California, should you have 8 Loofahs, 8 visits and still have a Loofah? And that answer is absolutely you could. You could have 2 visits in your first episode that created a Loofah based on your diagnosis code, and 6 in your second 30-day payment section. And depending on your diagnosis code, you could have done 8 visits in 60 days and still come up with a Loofah. So you can see how Loofah is going to add a lot of challenges to agencies, and how Axxess Care is going to be able to be a tool for you to use within agency core that's going to help you be able to control those Loofahs. We're worried also about the non-specific coding. We use a lot of symptom codes. We use a lot of gait abnormality, which, by the way, is not going to work under PDGM. It's going to create 0 revenue for an agency. And we use that non-specific coding a lot of times because we don't get the information from our referral sources that we need to be able to code specifically. So under PDGM, it's going to be very important that we have a good relationship with our referral sources to get additional information we need to provide those codes that's going to create a clinical grouping. Routes will be eliminated for new agencies after 2020, and we believe that down the line, routes are going to be eliminated for all agencies. Remember, we're going to a 30-day payment within that 60-day episode. So we feel like that's the next progression, is complete route elimination. And then there's something called a behavioral adjustment wildcard. And basically what CMS is saying is when they start noticing that our patterns change towards diagnosis, coding, comorbidities, and Loofah avoidance, they're going to hit us with a penalty of close to 6.5% reduction in revenue. This particular behavioral card adjustment is something that we are lobbying against our National Home Care and Hospice Association. You can actually go on their website and you can let your voice be heard to your Congress people and senators that please eliminate this behavioral adjustment wild card. That is almost a 6.5% reduction in our revenue. Agencies can't survive with that. And I believe firmly that home care and home health is the best delivery method and the most cost-effective delivery method. And by penalizing us with this behavioral adjustment wild card, it's going to de-incentivize many, many agencies to keep performing home health. So our risk indicators. And again, as I said, your individual agency will have a different set of risk indicators depending on what your population looks like. But the biggest risk indicator is probably going to be that Loofah, controlling those Loofahs and those missed visits. That's why Axxess Care is such a powerful solution for our Axxess customers. This solution is only given to Axxess customers. That it is not for public, and believe me, a lot of other agencies not on Axxess have asked could they have Axxess Care as well. They want this for this Loofah control rate, because in a few slides I'll show you what that impact makes to the financial statement, missing just one visit. Loss of revenue. We know some of our agencies are going to lose revenue because maybe they do have that high population of patients that don't come from the hospital or the SNF. So there is going to be a drop in revenue for those agencies, which is why it's so important that we do cost containment. And I will show you ways that Axxess Care can help control your costs as well as control your Loofah rates. Therapy utilization. So how are we going to meet those rehab outcomes and do it in a way that's still cost effective? If you're an agency that's seeing a great number of therapy patients, then you may be at a potentially high risk of a lot of lost revenue under PDGM. And if you don't know if you're a high utilizer or not, you can always check your Peppers report, and it will show you how you compare to other agencies as far as your therapy utilization. Case management and documentation is very important under PDGM. We have to show medical necessity for not only our primary diagnosis, but our secondary diagnoses, because those are tied to reimbursement. So it's going to be very important that our documentation is up to standard, that we're actually getting our documentation in a timely manner. Episode management, the ability to be able to look at your schedule and manage that episode is going to be vital in PDGM. We have to control not only missed visits and Loofahs, but we have to look at the resources that we're giving our patients. Again, with Axxess Care, we're able to see this in our system, and we're able to adjust that scheduling and adjust that visit utilization as needed to make sure patients have appropriate resources, but still look at cost containment. Staff education and training. I can't encourage this enough. I've probably attended 20 PDGM webinars to date, and I have learned something new from every PDGM webinar I listen to. So I encourage you to have your staff attend trainings. Axxess will be offering trainings throughout the year. We will also have tools available on our website. So please encourage staff members to utilize these tools, to watch these webinars, and to obtain as much education and training as possible surrounding PDGM. Referral source, we talked about that community versus acute. And just know that if you're in that area where you're seeing a lot of community patients, you still have time to build up those relationships with acute care providers. And you also will maybe want to look at how we manage chronic care using management and evaluation of care plans to do that. Coding. Looking at coding is probably, even though it's listed last next to Loofah, it's one of the most important PDGM risk indicators. We have to make sure our primary diagnosis is fit in one of those 12 categories. And again, half of the codes aren't going to work under PDGM. So we want to make sure we choose the appropriate code, and we want to make sure that our comorbid diagnoses are supported in our care plan. So taking a bit deeper dive into our standard payment rate, let's take a look at what we currently make under PPS. Our average rate is $3,154 in a 60-day period. This does not include our non-routine supply add-on. Under PDGM, remember we're going to a 30-day payment. Our standard rate is $1,753.68, but it does include our non-routine supplies. It's already built into that rate. What it doesn't include is that 6.425 behavioral adjustment wild card I spoke about. We hope that that's going to be repealed and go away, but we do have to plan for that there could be an additional adjustment that goes into that $1,753 rate. So looking under our current system, if we look to the left, we see that admission source and timing now comes from OASIS. Under PDGM, that's going to come from claims data. And you'll see a trend that almost everything going forward in PDGM is going to come from claims data and not from the OASIS, besides the functional domain. Clinical domain is not going to come from OASIS anymore. It's going to come from the primary diagnosis on the claim. Again, functional domain under PPS will still be functional domain under PDGM. Service utilization from under PPS comes from the OASIS. And remember, that's the therapy utilization. We're not going to have that under PDGM, nor are we're also not going to have non-routine supplies. And then here's the biggest at the end. Look what we're moving towards, from 153 home health groups to 432 PDGM groups. That's a lot more opportunity for errors when you move from a payment system of 153 to 432. So looking at that makes it complex in and of itself. Under our home health PPS that we're currently paid under, all billable visit counts for visit utilization. So in other words, all disciplines, home health aid, skilled nursing, PT, OT, ST, that all counts towards your utilization for Loofah. Under PDGM, the same. That's not a change, which is very important because we want to start looking at maybe using our paraprofessionals more as we look at cost containment. Under PPS, fewer than 5 visits create a 60-day period, create a Loofah. Under PDGM, like I spoke about earlier, that threshold is going to vary from 2 to 6 based on the clinical grouping, and it's also going to be on a 30-day billing cycle. So that's a whole level of complexity that's going to be involved with managing those Loofahs. At this point, I want to turn it over to David Merck with Home Health Goals. He's an expert on data analytics and PDGM impact, and he's going to talk about this slide and the case studies that he has performed.
Thank you, Tammy. As Tammy has talked about this, you may have been wondering, why on earth are we talking about this now? After all, it's 10 months away, and we've been talking about it for a while, actually. What's the big deal? The big deal is that there are financial risks, there are significant financial risks that are hidden to some degree by some of the conversation that we have had. You're all aware that CMS was required when they created PDGM to assure that it was revenue neutral. To help in this, they produced a study. They did a study looking at all of the dollars, all of the episodes paid for under PPS in 2016, and they compared that revenue with the revenue that those episodes would generate in under PDGM. They normalized the revenue in both periods to 2019 payment rates. And when they looked at it, they said it all matches up. We've got $16 billion that was paid in 2017, and there'll be $16 billion paid under PDGM, or 2017, and there'll be $16 billion paid under PDGM. When they did that, they totally ignored one category of payment. Let's talk for a minute here about these two slides and the size of the slide. You'll note that they're both these two pies are both the same size. This is because they both represent the same 2,330 episodes from a sample agency. When we look at those and look at it for 2017, we see that there are two categories of payment. One is that you get full payment for the entire 60-day period. The other is that you get about 15%, in 15% of the cases, in this instance, payment on a Loofah basis for a significantly smaller amount of money, about a sixth as much, based on the fact that the utilization of visits was low. When you go to PDGM, you see four types of payment. You have your Loofahs. You have full payment for the full period. You also have the circumstance where you can get paid for one of the 30-day payments at a full rate and either nothing or a Loofah for the other portion. And then in that upper right corner, 13.4% in this instance, no payment at all. When CMS compared the dollars from 17 under PPS to the PDGM value, they totally ignored that 13.4% of the cases where no payment was received. In other words, when we did this calculation, we looked at the payment for all 2,300 episodes. We said the total PPS payment was 6.4 million and the PDGM would be 5.7, a loss of 6.6 or 665,000. What CMS did was said that the total PPS payment was really going to be about 5.7 million because they did not count the money that was paid in 2017 for the payment for the episodes which will not be paid anything in under PDGM. What that means is that agencies have had revenue that they've been using to pay for staff, pay for visits, pay for care that will no longer be available, but that loss is not being acknowledged by CMS. And when you look at the total package and look at the dollars that were actually shown, again, they said 16 billion under 17, 16 billion under PDGM. In reality, the dollars that were paid in 17 was much higher than 16 billion. Again, in that instance, as in this instance, a loss of somewhere in the neighborhood, generally, as we've studied agency by agency, of about 15 to 20%. So it's a significant deal. If you felt comforted by the CMS projections, you need to reconsider. Why are there those unpaid episodes? Tammy has told you, primary diagnosis. And as we look at diagnoses, the instance of the use, continued instance of the use of R codes is great. The use of codes that are unspecified is great. They have reduced the number of diagnoses that will be accepted for grouping an episode. They've reduced that from 72,000 down to 42,000. It's basically a 40% reduction under PDGM. Just a little additional bit of fact checking. You'll notice that in this case, the Loofahs have actually increased substantially. And in some projections, we've seen them increase much more. And in fact, you can have 9 visits in a 60-day period, and both the first 30 and the second 30 will be treated as Loofahs, depending on the levels that occur for each of the HERD categories that you've been assigned to. In addition, one last bit of fact checking I'll mention is that the CMS has indicated that there will be no increase in billing work. We're just beginning to see what the different kinds of new requirements will be for billing as we look at the role of resumptions of care and potentially SCICs, the 05 other assessment types of assessments that are done under OASIS, what the implications of those are for altering the various determinants of the payment of care for subsequent 30-day periods. So again, on all 3 scores, There are rumors out there, there are claims out there that do not bear up under analysis. So when I look at PDGM, I think that they've done a reasonable effort. CMS has tried to cut down on gaming risks. They've cut down on, they've tried to make sure that people who were being neglected in the system, that the resources were there to incentivize care for them, that they would get the care that they needed. And I think that those things are reflected, and that in the event that you had the right diagnoses for all of your assessments, this would in fact be a revenue neutral event. However, it is not the case that you're going to have all those diagnoses if what people tell me is correct. The basic word is we don't have the right diagnosis there. We don't have an acceptable diagnosis because we don't have the information that we need to get from the referring party. The reason you need to think about this now is that you need to begin now to change that fact. That's the only way those big losses are going to go away. That will require the time that we have remaining. Thank you.
Thanks, David. I think it can't be stressed enough that we have to start preparing now, because there's a lot of work to be done, as David just showed you. That was a large agency, but even smaller agencies, we're talking about a substantial hit to your revenue that could be happening under PDGM. So preparing and using tools that are available to you now is going to be very important. So let's kind of go into Axxess Care as one of those tools. One of those tools to leverage your advantage under PDGM, and in fact, leverage your advantage now. Loofah avoiding is going to be huge with Axxess Care. We're able to use this product. You're able to use this product to prevent those missed visits. And I'm going to show you how much one visit is worth. For cost containment, some of you are going to have a hit in revenue no matter what you do. So it's going to be very important that you contain costs so that there's more left over at the end to drop to the bottom line. So Axxess Care helps you to contain those costs as well. Program development. You can use Axxess Care to develop new programs, scale new areas. It's going to be important that we diversify with PDGM. Maybe that means going into new territories that's covered under your license. Maybe you can pick up another zip code. And Axxess Care allows you to do that and gives you a tool to support that growth. And then the rehab management. We're going to still have to produce those excellent outcomes. And so Axxess Care can allow you to manage patients more effectively and get those good rehab goals. So if we look at our statistical data from CMS, I just want to show you basically how we've been taught to schedule in home care. Ever since I've been in home care, we've been taught to front load visits. And you'll see the first 15 days, we do about double the visits for nurses as we do in the last 15 days, from day 46 to day 60. And it's the same of all of our utilizations, our PPOT, AIDS, MSW. We always do more in the first 15 than we do in the last 15. Why is that important? Because more than likely, this is going to create a loofah in that second 30-day period. So this is what we're dealing with when we look at that loofahs and that complexity of managing loofahs. So let's look at what our Loofah rates are for 2019. On the left, you can see that I'm going to focus on nursing. You can see that nursing Loofah rate is $146.50. So currently, under PPS, if you don't make 5 visits, let's say you make 4 nursing visits, you're going to get paid 4 times $146.50. That's going to give you $586. So if we take that model and we transfer that to PDGM, look at that 30-day visit rate without Loofah. Without a Loofah, your agency will make $1,700, $1,753.68 under PDGM for a full 30-day payment. But what if you only did 4 visits and this was a 5-visit Loofah threshold for this patient? Rather than getting that full payment, your organization's only going to get $586. You're going to lose over $1,100 in revenue. That's a complete loss of revenue because you missed one nursing visit. So the cost of one nursing visit costs you over $1,100. Let me give you a scenario on this next slide. You're very good, your clinical manager, your director of nursing is very good at looking at the schedule and managing those episodes. Hopefully they're using Axxess Care to do that. They're scheduling using this very robust product that helps you see if you're going to miss a visit. And they get to, let's say, day 28, and they see that there's 4 visits and there's another visit scheduled for that day. But Nurse Sally calls in, and Nurse Sally says, you know what, I am so sick, I cannot get out there to see my patient. And so we know that we don't have any staff available to pick up that visit. So we post that visit, and we put that visit out there for Axxess Care, and we have a nurse decide to pick up that visit and perform that 5th visit for us on day 29. So we posted the visit for about $50 because we're going to incentivize it. It's very important that we get that visit. You know, we're going to give them a little extra money to make sure we get that visit made. At that point, because you avoided a Loofah, you're going to drop over $1,100 to the bottom line. That's how much money that one nursing visit made you using Axxess Care, $1,100. Let me give you that same scenario. And as an operator of large home health agencies, one of my biggest challenges was weekend nurse visits. It was very, very difficult for me to get weekend coverage. I often had to resort using a staffing company, a traveling nurse, which cost me up to $75 an hour. But we had to do it because we had to meet those needs. But something I came up with is my director of nurses, my clinical supervisors, and branch managers, sometimes they wanted to pick up those extra visits on the weekend, extra cash in their pockets for the weekend. And I would send out an email blast to all 27 offices and say, I am going to incentivize visits this weekend, and I'm going to pay the rate of $150 for all admissions done on the weekend. And then I would have a blast of people emailing me back and saying they would take visits in this area and they would take visits in this zip code. They could do this many visits. So all day Friday, myself and a support staff person managed that weekend schedule with the additional staff that we had calling in. If I'd have had a product like Axxess Care, I could have posted this internally to my staff. I could have showed where those visits were located. My staff could have accepted those visits, and it would have all been managed without taking me all day on Friday till about 9 p.m. to get the schedule done for the weekend. So I think that internal posting of Axxess is just as important as that external posting. It also creates very satisfied nurses because we're not on the phone having to call and say, can you take extra visits? Can you take extra visits? So I just want to throw that out there as a solution for you with Axxess Care as well. Look on the right-hand side. We just launched our Rehab Program so that we can actually post OT and PT visits. So these are nurses that you see on the right, but very soon you'll be able to see physical therapists, occupational therapists. But what Axxess Care allows you to do is to rate these nurses and therapists using a 5-star rating, very much like Uber. And it also tells you the years of experience that they have. So why is that so important with rehab? When I'm looking to control my utilization of rehab, I want to be able to perhaps lessen my visits by using someone that's very skilled and very knowledgeable. I may even want to reduce my rehab staff. Maybe I have 3 PTs, but because of PDGM and cost containment, maybe I have to go to 2 PTs. But I know that rehab is very cyclic and it's ups and downs, and we have our peaks and our valleys. So I have to have someone to pick up those visits in the time when I get an increase of rehab patients. What better way to do that than to post rehab visits using Axxess Care? Use your 5-star rating and pick those therapists that match your profile and your needs for your rehab patients. It's going to it's going to decrease your full-time equivalents, your FTE. It's going to provide additional opportunity for physical therapists, because I believe in 2020, our therapists are going to want to pick up more visits because there's not going to be as many visits readily available to them. So this is kind of one of those win-wins. We get the value of good rehab outcomes. We get the value of decreased costs, and our therapists get the value of being able to increase their financial situation and pick up more visits. Really quick, I want to talk about healthcare reform that happened in 2012 with the Jimmo versus Stabilis case. If those of you that aren't familiar, you can look this up, but basically what it says was that Medicare now agrees that services will be paid for people that are needed to maintain the patient's condition and prevent or slow deterioration. In other words, they don't have to show improvement. Medicare was sued by a group of chronic care individual organizations like the National Alzheimer's Organization, the Disabled Vets Organization, the Parkinsonism Organization, because they said that they were being discriminated against with home care. And CMS agreed and said, you're right. We have to be able to provide care to patients, even though they're chronic in nature. Under PDGM, we're going to be able to do that using management and evaluation of care plan and maintenance therapy. How can Axxess Care help you with those 2 skills? Management and evaluation of care plan is a very specific skill. It takes a high level of knowledge to be able to document this. You can actually request for that skill set on Axxess Care and be able to look at those nurses that have years of experience. Those nurses with those 20 plus years of experience have more than likely performed M&E before. They're familiar with it. And maybe your nurses are not. Maybe you don't have nurses that have that kind of history in home care. So Axxess Care actually allows you to develop revenue stream using management and evaluation of care plan as the skill. Also can use maintenance therapy as a skill. Both of these require very specific documentation guidelines, and they do require an RN and a PT, an LVN and a PTA. I like management and evaluation of care plan because generally you just put 2 RN visits in there a month, and you have your unskilled care, your paraprofessionals, your home health aides provide those skills 2 days a week. So there's 2 things that does for you. It decreases your cost because you're using more cost-efficient caregivers, and it also helps you control a Loofah or avoid a Loofah because you're doing 8 home health aide visits and you're doing 2 nurse visits. That's 10 visits in a month. That avoids the Loofah on both ends, both your first 30 days and your second 30 days. Axxess Care internal posting. Again, I just want to show you what that looks like on the right. And we can see here that you can post what skill set that you need. With management and evaluation, these are actual real examples. Nobody has posted for M&E yet. I think a lot of people got very frightened about M&E a few years ago when there was an educate and probe on M&E. I can tell you I've used it, and I've been very, very successful using this as a skill. So if you wanted to post for that M&E, in your section there where it says home pumps and insertion and discontinuation and bladder training, you would post and put management and evaluation of care plans. And if you're posting internally, hopefully you've trained your staff up that they know about M&E, and they're only going to accept that skill set if they can actually perform that skill. Again, this is going to promote patient satisfaction scores. Our patients love home health aides. They like to be seen more often. It's going to help prevent your Loofah, and it's going to help promote medical necessity. So a couple of success stories. Jessica is one of our customers that says Axxess Care helps my agencies and my clinicians succeed. And Dawn, one of our nurses, talks about completing all my documentations in the patient's home is easy. They can do it from their iPhone. And it's a quick, easy way to complete your documentation. And it gets in quick to you as an agency, so you can make sure that that visit utilization is being met, because remember, that's going to prevent a Loofah. So let's look really quick at a case study, and this is from our Texas Center for Nursing Workforce. Why do nurses leave? Nurses leave because of documentation requirements. That's why they leave home care and they look for other jobs. The second reason they leave is because administrative staff get tired of doing double work. They're having to do visits out in the field, and they're also having to cover all the internal work that has to happen administratively for clinical managers and clinical supervisors. And the third reason is listed as personal reasons. Well, when we dug into personal reasons, we found out those personal reasons related to the top bullet, increased workload. They're tired, they don't want to drive, they want to have a work-life balance. Using Axxess Care, we can group patients in geographic territories to prevent our staff from having to drive, to prevent them from having those increased workloads so they don't burn out. And let's look at that as a cost containment measure. If we look at salaries.com and we look at the average cost for retention and training of a nurse, what does it cost us for that nurse to turn over? Anywhere from $37,000 to $58,000. Looking at cost containment, that's one thing we don't want to happen during PDGM, is to lose good nurses because they're fatigued, they're overworked, or they're traveling too much. So employee benefits and cost savings. Let's take a look at this. If we look at full-time staff, their benefits cost an average of a little over 31% of their salary. If we look at these cost savings, we show that we can save almost $25,000 in cost savings for not having to pay those benefits of a full-time equivalent. Because remember, under Axxess Care, you're not having to pay the additional Social Security, the medical benefits. That all rolls up, the PTO time, that all rolls up into a cost benefit savings for you. And some of you may use a large mix of part-time and per diem staff. That's a cost savings as well. There's benefits that you have to pay to those staff, such as Social Security, Medicare, workman's comp. Looking at an average routine visit of $40 with an average mileage reimbursement of $5.45 for 10 miles in between patients, we can save $8.91 a visit, a 20% cost savings on every visit made by your staff. Other areas that will save you time, it will save you money, it will streamline your operations is Axxess Care performs all your background checks. You'll see those to the right. It does your OIG background check. It does your criminal background check, which could be $50 to $100 depending on your state. It verifies your license. And it also prevents you from getting survey fines because all of this information is housed and readily available to you to show a surveyor. And it's all done through Axxess Care Solutions. That's a burden that you can take off of your administrative staff. So looking at our timeline, what do you need to do to prepare for PDGM? Do a risk assessment. Determine where your risks are and develop a plan now. Look at industry partners perhaps for coding and telehealth and professional services. Educate your staff now and all throughout the rest of the year. When you develop your plan, you're going to want to beta test that in Q2 and start educating your referral sources in Q3. By Q4, you should be able to revise your beta plan and re-educate for what didn't work. And by November 2019, you should have a plan developed that you're very comfortable with for the go live date in 2020 for PDGM. So my recommendations to you, start internal posting now. So if you've not tried Axxess Care, get familiar with it, start the internal posting, and then begin external posting. You don't want to wait till PDGM hits. It's still a powerful tool now to control lupus and to decrease your cost. Know your per visit rate. You don't want to lowball your visit rate so you can get those quality nurses to accept visits. And just like my example showed, even if you are above the visit rate, you're going to save all that money. The 20% of that's going to be saved with money that you don't have to pay for FICA and workman's comp and all those other things that were listed out. Post consistently so you can retain that quality staff. Nurses want to work for agencies that they feel comfortable with and that know that they're going to continue to give them visits throughout the month, the week, and the year. Post in clusters in geographic areas so that a nurse can pick up all those visits. Maybe she doesn't even live near that zip code, but because there's 5 visits in that area, it's worth it to her to drive there and see those visits all at one time on one day. And communicate with our Axxess Care staff, with your Axxess Care staff, because there's continuation of use. Make sure that you have communications with them and you help onboard them with anything specific that you do for your agency. So prepare now for PDGM with Axxess Care. It's going to help you contain your costs, prevent your lupus, increase your management of rehab and improve those outcomes. And it will help you with your program development. And I gave you the example of management and evaluation, but it could be IV therapy. It could be wound therapy. There's many, many specialties that maybe you don't have in-house that if you use Axxess Care, you would be able to get nurses with that skill set.
Fantastic. All right. Thank you, Tammy and David, for teaching us all how to succeed with one of the biggest adjustments for the industry in many years, all through using the powerful scheduling and staffing solution of Axxess Care. So remember, for those of you who are Axxess clients in Texas, Illinois, or Massachusetts, today, Axxess Care is already included in your agency core subscription. If you'd like to join in thousands of agencies that are successful using Axxess, please submit your name and contact information in the questions box, and a member of our team will reach out to you today. Thank you, everyone, for joining us today as we deliver on our mission to empower healthcare organizations and professionals with the world's best technology solutions.